This afternoon, we are going to start with some reflections, and in a minute, I'm going to come to Katie and Stephen, who are public members of the Bristol Health Partners Executive Committee. I think I've just realised that I've failed to introduce myself. You can probably see my name on the video, but I'm Julian Walker. I'm a psychologist by background, and I'm R&D director for AWP, the Mental Health Trust. But I've been on the exec team sort of since Bristol Health Partners was set up. And over the last year or so, we've been trying a slightly different way of punctuating that exec meeting with a reflection. And it's a technique that I've used in other situations, and we're going to show you a little bit about how we do this today. So what we do is we run the meeting about halfway through. So let's say we had an hour's meeting. About halfway through the meeting, we would do what we call a PPI, pause for reflection. So PPI is patient and public involvement. And so the people that have joined as members of the public or patients on that exec team will have a conversation. I sort of facilitate it, but it's mainly a reflection by the people on that committee. Now, the committee just have to sit there and listen to what we've got to say, and then we don't really like them to butt in or reply or respond in any way. We just let them carry on with the meeting subsequently and see how it goes. So if I could get Katie and Stephen's videos now on and unmuted.
Hi.
Hi, Katie. Hi, Stephen.
Hello.
I think it would be all right we could pop that slide down so that people can see us. So this is just like we would normally do this for an exec meeting, isn't it? That
yeah.
We'd be in a group with a number of other people. 53 people in the call today, so that's 50 other people. And then I would normally sort of ask you a couple of questions, and we'd talk about how the meeting had gone, and we'd give it about 10 minutes and then we'd carry on. So I suggest that we do the same. So I'll be asking you a bit about sort of how the last couple of days have been in the HIT conversations, a bit about what it was like to do that, and then maybe a bit about what topics came up. So
we should introduce ourselves a little bit about what we're involved in and to do with
yeah,
HITs.
absolutely, because you're both involved in particular HITs, aren't you, as well as sitting on the exec?
Yeah.
Yeah, I mean, far away, Katie.
Okay, so I am Katie Legg, so I am the Patient and Public Involvement Lead for the Eating Disorder Health Integration team, and I also work with the Bristol Bones and Joints HIT as well. So just a little bit of background about which two HITs, and I have a special interest really in mental health.
And did you attend both the last 2 days? You did, yeah. Okay. Stephen.
Hello. I'm Stephen Hill. I'm an archaeologist by background and a stroke survivor. And I'm a co-director of the stroke HIT as the PPI lead. And I'm, as you know, I'm the executive of Bristol Health Partners, and some of you will have heard me in the last couple of days as you heard Katie.
So how have the last couple of days been? I genuinely haven't been able to attend them, so I was keen to hear from you about what it's been like. I mean, what's it been like going online? How have the conversations gone?
Do you want to start, Katie?
Yeah, it might help, Julian, if you ask which one of us, because otherwise we're both too polite. Yes, I think they've been fantastic. Personally, I really liked the breakout rooms. I thought that how it's been run online has been brilliant. How a little message just pops up on the screen and you click on it, and then you're already allocated into a breakout room. And then within that breakout room, I found the conversations yeah, just really like natural, easy to talk to each other, brilliant shared experience to, you know, you learn so much, even though you have different interests and your health integration teams are of different, you know, content. It's brilliant how much you can learn from each other, and some of the shared themes as well, which I think we'll come on to in a little while, maybe.
So I can't quite tell whether you're saying it's better or worse than, I mean, are some bits of it better than face-to-face and some bits of it worse? I think we've been worried that going online would sort of make it so much more difficult, and it has been a bit more difficult. But you're saying that some of it is some of it better, or has it worked in a different way?
I think it's the I wouldn't want to replace a face-to-face conference,
No.
but I think it's been fantastic as a completely different thing. Like I'm going to probably sound like a complete idiot now, but I'm going for it. A bit like, you don't just have one pair of shoes, do you? You have different pairs of shoes depending on what you're doing. And actually, like, the online environment has been, I think, brilliant. I think for somebody, I have chronic pain, and I have fibromyalgia as well. So I don't think I would have managed to have done so much this week, even if it had been on one day. I remember last year I couldn't attend the whole day. I was absolutely wiped out after sort of lunchtime. So I felt much more able to engage, and I wonder if other people maybe have felt that, or been able to duck in and out with work.
Yeah, interesting. What's been your experience, Stephen? How's it been, that sort of transition from face to face to online?
I'm going to start with something that's bleeding obvious, if you like, but I'm sitting here in my wheelchair, and it's an awful lot easier to attend a virtual event. I don't have to struggle into a building. I don't, as happened at previous HIP conferences, have the problem that it's extraordinarily difficult to weave my way around people when I'm in a sort of chair or a buggy or whatever I've got. So in that sense, that makes a difference. On the other hand, I felt that the plenary bits felt more remote, and normally when I'm about to talk to a lot of people, there's a sort of adrenaline rush and you're hyped up to it. Somehow it being distant has taken that away, which I found quite interesting. It's felt more clinical, more, I don't quite know, more objective in a funny sort of way. And I miss, obviously, seeing everybody's faces, because Zoom only lets me see 9 people. So the audience reaction I'm used to isn't there. I found, like Katie, the chat rooms were actually excellent. I felt at home in them, and they've been the nearest to those sort of serendipitous things that happen in a conference when you mingle with people over what can be quite disgusting cups of dodgy tea or coffee. And that's that mingling is one of the great things about conferences that this makes more difficult. But I wouldn't like to say whether I thought it was better or worse. I'd say it was just different. It's been an interesting experience. And in terms of capturing experiential learning, I think it's actually been much better. And the fact that it's possible to record things and get back to them will, I'm sure, bear fruit in the future. So I think lots of positives. The negatives have been entirely bearable and livable with. And I think we should do it again. But I don't think, like Katie, I don't think we should abandon real face-to-face events either when it becomes possible again. Yeah,
I've really missed the face-to-face side of it. Yeah, I agree. So what kind of things came up? Do you want to carry on, Stephen? Do you want to say something about the sort of content topics that you noticed?
Okay, well, I'm a dyed-in-the-wool, boring old academic by history with an interest in adult education, and I've been thoroughly enjoying the experiential learning actually being captured and coming out in the breakout rooms. And these have been sometimes quite surprising, but it's been really encouraging that other people's reactions to what's been going on in the COVID emergency actually are quite like mine, and that nobody was saying it's all bad. I think we probably all went into this thinking it's all bad, and we'll come out of it thinking that was one of the most dreadful things that ever happened to us. But it's been really interesting to see the sort of reflective practice going on around me where people were saying, well, actually, you know what, we achieved something very quickly that we might not otherwise have achieved. We've learned things about working in a very different situation. For me, the thing that's been a bit strange is, and I'm now talking with my stroke hit hat on for a minute, that the conversation has largely been about chronic conditions and about community-based stuff. Whereas through this COVID emergency, what's been impacting on me most greatly has actually been capturing what happened to inpatient experience, because of course I've realized that the stroke hit's a bit different from the others, and we're dealing with a subject which is all about a catastrophic, disastrous event that you would not have predicted and how you live with that. And we've been interviewing, in the context of the stroke transformation program, we've been interviewing people who've actually been stricken during the COVID emergency. And I've several times heard the story, and it's been very difficult listening, about people who've had a stroke, come to in hospital, paralysed, surrounded not by their family or their friends, and being treated by people who are effectively in armour, in PPE. They can't see their faces. Communication is very difficult. And unless they scrawled their name across their tunic, don't even know that. And that's been very frightening to people. And I suppose I'm thinking all the time, what's the deluge going to be when this is over? What sort of mental health problems will come out of this? How many people will have had transient ischemic attacks that didn't dare to tell anybody because they didn't want to go into hospital, and talking to GPs has been more difficult. But the conversation around me has been much more about what was going on in the community. So I felt detached from that, but very interested to hear it. So it's caused a lot of thinking, really. But I've loved the experiential learning and the reflections on that. Maybe I should stop there and hand over to Katie.
Yeah, I was going to say, so that point about the communication in hospital came up with Leah Oven on the day one panel, didn't it? So Katie, what sort of content points have you noticed?
I mean, we were in an interesting conversation yesterday with quite a lot of people that are interested in chronic pain. So from the chronic pain hit and the BBJ hit. And there were some really interesting conversations there about like peer support and some good practice. I think Sabitha also talked about it in the HIT conversations around, she was talking really clearly about providing like peer support about how to access groups, or so say for example you were meeting as a Zoom group, that she would meet people beforehand and online have a chat a little bit more like that community, having a cup of tea, and then also in talking them through how to join, how to like participate in the group.
Yeah.
And then in the chronic pain sort of conversations we were having yesterday, again I think it was the pain services, I think they do a similar thing like a body service, and they're translating that over to being online. I thought that was something that a lot of people could take away for that confidence around. I think we also talked a lot about accessibility and how actually, you know, even this conference we are relying on people having access to, you know, computers and Wi-Fi. I mean, I think we need to all think about that and how we can improve that in our own communication right now.
Yes, it's another type of inequality, isn't it? We've talked, definitely on day one, we were talking about race and socioeconomic status and obviously other protected characteristics, but digital inclusion and exclusion is critical as well. I like the idea actually of just contacting people beforehand, a little bit of coaching, a little bit of encouragement. I mean, in fact, I did that for all the people that we had on the panel on day one, actually. So I think it's that's a nice sort of practical take-home tip, really. And also just the point that different people might need different things. I mean, we're reflecting, aren't we, on people with different conditions in different settings, community versus inpatient, and people with different challenges who might have experienced COVID-19.
I think we should be leading the way in that as health integration teams. I mean, talking more to the public, finding out what people need, what people want to be able to have that access in. I think there were some brilliant conversations. I learned so much on day one from those conversations with the panelists, taking a lot away to think about. Something I thought, you know, even we could improve on next time if we do anything online is I saw an excellent app where paramedics hold up their phone and it actually dictates your spoken word into subtitles. So actually, I mean, I'm sure there was something maybe we can think about for doing something like this online again to make even, you know, I know that on day one we had someone signing. That would be great, wouldn't it, if we could even have that now? I mean, technologically wise, I'm sure the excellent Autumn Live who are helping us with running this would be able to think about that.
Yeah. Okay. So unless there's anything else, I'm going to we'll go into looking at our videos. Was there anything else from either of you that you wanted us to sort of take away from this discussion?
Chip in one thing. I was absolutely fascinated yesterday afternoon by a chat room where we were talking a lot about arts-based therapies, about the importance of going outside, and all sorts of things that I was delighted to see that the professionals were actually talking about things that one knows sort of instinctively, but on the basis of no evidence, no real evidence, that they ought to be and should be and are very effective. And what I derived from that, which I thought was important, was the extent to which it was clear that actually there's a huge amount of common ground between the hits. And I wonder if we normally miss a lot of that, but in the sort of blitz spirit we're in at the moment, sharing those sort of things, well, I learned a lot. It took scales off my eyes, and I think there's learning that we mustn't lose from that.
Yeah. Katie, final word from you?
No, just that I've been learning lots, and I think it's great. I mean, the health integration teams, how, you know, more members of the public and people that are specialised in their area. I think it's such a great format, isn't it, to learn from each other, and we can do more of that. It
is, yeah, and that's partly the purpose of the HIT conference, isn't it? Is to get the hits working together, collaborating, some learning across the different hits, 20 odd hits that we've got increasing every year. And so that's part of the purpose of this conference, and also to, as you've both reflected, to stimulate and cause people to think and be interested in the things that are important to the public and to service users and to services. So thank you very much.
Thanks.
We're going to I look forward to catching up with you after the conference for further reflections, but we will now say goodbye to Stephen and Katie. Thank you very much.